Welcome to Key to Pharmacology. I am Dr. Sehrish Zaffar, and those who are new here, I am Associate Professor of Pharmacology at CMH Lahore Medical College. Let's start with the drugs that are used for the treatment of asthma. Asthma के हर टेबल ऑफ स्पेसिफिकेशन में सेपरेट मार्क्स होते हैं और बहुत रिपीटेडली पूछा जाता है कि विच ड्रग्स आर यूज्ड फॉर द ट्रीटमेंट ऑफ एक्यूट अटैक while which drugs are used for the long-term prophylaxis. We are going to see the case study that is given in the big Katzung here. The case study says that there is a 14-year-old girl with history of asthma requiring inhaled corticosteroid therapy. She has allergies to house dust mites. Present kaise kar rahi hai with worsening shortness of breath. There is audible inspiratory and expiratory wheezing. She has got tachycardia. Her pulse is 120 beats per minute. She has got a respiratory rate of 32 per minute, which is high. Her mother states that she has used the albuterol inhaler several times for the past 3 days. वो repeatedly use कर रही है उसको, but the inhaler did not seem to be helping, so she stopped taking it. The question is, what emergency measures are indicated and how should her long-term management be altered? Students, mind this thing. Asthma की यही दो aspects हैं which are most important clinically and with the exam point of view. What is the acute treatment? What are the prophylactic measures? Starting off with bronchial asthma. Asthma is a clinical condition characterized by recurrent episodic bouts of cough, shortness of breath, chest tightness and wheezing. Patient को bronchospasm feel होता है, उसकी वजह से उसको सांस लेना मुश्किल हो जाता है. बार बार रिपीटेड खांसी आती है. ये खांसी इसलिए आती है कि पेशेंट जो है वो क्लियर करने की कोशिश कर रहा होता है अपने एयरवेज को, विच आर फुल ऑफ म्यूकस एंड दे आर नैरोड डाउन एंड द थिकन्ड वॉल्स डू नॉट लेट द पेशेंट ब्रीथ प्रॉपरली. इसकी पैथोफिजियोलॉजी क्या है? देयर इज एन अर्ली रिस्पॉन्स विच इज immediate contraction of the airway smooth muscles leading to acute bronchospasm that makes breathing difficult. This is followed by a late response जिसमें inflammatory changes आती हैं which lead to mucosal thickening, edema of the respiratory lining, mucus hypersecretion, increased bronchial reactivity और remodeling हो जाती है mucosa की, कि जो mucosa है, जो respiratory lining है वो thick हो जाती है और वो narrowed हो जाती है और उसमें जो cells हैं वो hypersecrete कर रहे होते हैं और बहुत ज़्यादा mucus वहाँ पे produce हो रहा होता है, जिसकी वजह से जो lumen है वो filled up होता है with mucus and secretions and inflammatory cells and that makes air passage difficult. ये basic pathophysiology है asthma की. If you look at the diagram in the big Katzung, वो बहुत well explain करती है सारी situation को. We can see that initially जो allergens होते हैं वो trigger करते हैं mast cells को and result in the release of histamine and multiple prostaglandins and leukotrienes. All of these cause an immediate early reaction by causing smooth muscle contraction leading to bronchospasm. इसकी वजह से acute phase आता है. Simultaneously क्या हो रहा होता है कि there is trigger and there is stimulation of interleukins, tumor necrosis factors, some long-term factors which are then causing the stimulation of proteases, platelet activating factors. ये सब inflammatory mediators हैं जो क्या करते हैं, inflammatory reaction को trigger करते हैं. फिर there is eosinophilic infiltration, there is edema, there is cellular infiltration जिसकी वजह से mucus hypersecretion and mucosal changes आती हैं which lead to a late consistent response that is mainly the inflammatory response. Lippincott में बहुत अच्छी डायग्राम दी हुई है जो बहुत easily आप visually understand कर सकते हो the difference between the normal bronchial tube और उसका lumen कैसा होता है और उसकी wall कैसी होती है and the asthmatic bronchi उनकी ओवरलुक कैसी हो जाती है, ल्यूमन कितना नैरो हो जाता है एंड इट इज फिल्ड विद म्यूकस एंड एयर पैसेज वहाँ पे कितना डिफिकल्ट हो जाता है. आफ्टर अंडरस्टैंडिंग द होल पैथोफिजियोलॉजी, what are the goals of therapy? The first thing that we need to make sure is that we have to remove the trigger that is stimulating the whole process. एलर्जन कौन सा है उसको आइडेंटिफाई करना समटाइम्स बहुत इंपॉर्टेंट हो जाता है बिकॉज इफ वी आर नॉट अवेयर कि किस चीज से ये बार बार ट्रिगर हो रहा है तो फिर वो अटैक तो होता रहेगा, रिकरेंट होगा, वी कैन नॉट डू एनीथिंग अबाउट इट. वी हैव टू आइडेंटिफाई द ट्रिगर एंड रिमूव इट व्हेनेवर एंड वेयरएवर पॉसिबल. लॉन्ग टर्म जो आप पेशेंट को ड्रग थेरेपी देते हैं उसका पर्पस ये होता है कि आपने एयरवे इन्फ्लेमेशन को प्रिवेंट भी करना है और रिवर्ट भी करना है. जब तक आप एयरवे इन्फ्लेमेशन को रिड्यूस नहीं करेंगे, म्यूकस जो प्रोडक्शन हो रही है, जो ब्रोंकियल वॉल की थिकनिंग हो गई है, जब तक आप उसको रिवर्ट नहीं करेंगे, तब तक merely bronchodilation is not going to help. So while we treat asthma with the drugs, what we want to do is we want to decrease the intensity and frequency of the asthma symptoms. That is mainly through bronchodilation. We also want to prevent future exacerbations. We do not want our patient presenting in the emergency with acute attacks. We want some prophylactic measures कि बार-बार attacks ना हो. And we want to minimize the limitation in activity. Patient को एक ऐसी permanent regime पे डालना है, long term prophylaxis पे डालना है, जिसके साथ उसकी physical activity hamper ना हो. For example, अगर कोई बच्चा है, उसको ये ना हो कि वो खेल नहीं सकता, exercise नहीं कर सकता, और उसकी daily life activities impair ना हो because of consistent repeated hospital admissions. To achieve all these goals, we have got a group of drugs that are used to treat asthma. There is a group called bronchodilators, which includes beta agonists, muscarinic antagonists, and methylxanthines. There's another group which is of the anti-inflammatory agents. This includes release inhibitors, steroids, antibodies, and slow anti-inflammatory drugs. And then there is a group of leukotriene antagonists. Why are they given separately? Because they are bronchodilators as well as anti-inflammatory drugs, so they constitute a separate group. This includes lipoxygenase inhibitors and receptor inhibitors. What are the different strategies while treating asthma? We have got reliever drugs, which are for the treatment of acute bronchospasm, जो promptly हमारे symptoms को relieve करेंगी. इस केस में nasal oxygen is the basic therapy for acute bronchospasm, चाहे वो जिस वजह से मर्जी हो, चाहे asthmatic हो, चाहे कोई और reason है, whatever is the case, if the patient cannot breathe, nasal oxygen is the first thing that you give to that patient, especially in an emergency setup. फिर आपके पास drugs में beta 2 agonists हैं, muscarinic antagonists हैं और theophylline है. The second group is controllers. Controller drugs वो हैं जो long term preventive treatment में आपकी help करेंगी. The most important anti-inflammatory drugs in chronic asthma are the corticosteroids. बहुत efficient role है और mainstay of treatment corticosteroids ही होते हैं. In addition, आप long acting beta agonist add कर सकते हैं and they help to improve the response to corticosteroids. अकेले long acting beta agonist cannot be used for prophylaxis, वो इतने efficient नहीं है. Then there are certain IgE antibodies जो chronic therapy के लिए उन patients में दे सकते हैं which are refractory to the regular anti-inflammatory treatment. Starting with the bronchodilators, we can see multiple mechanisms जिसके through bronchodilation achieve हो सकती है. अब bronchial tone अगर cyclic AMP increase कर जाए तो relaxation कराता है. We can see that beta agonists cause increased production of cyclic AMP. We can see that theophylline inhibits the phosphodiesterase enzyme and inhibits the breakdown of cyclic AMP. Both of them increase cyclic AMP leading to smooth muscle relaxation. On the other hand, we have got muscarinic antagonists which prevent bronchoconstriction that is caused by the M3 receptors. There are leukotriene antagonists which prevent bronchoconstriction that is caused by leukotrienes. And theophylline also inhibits the adenosine receptors. Adenosine receptors also cause bronchoconstriction. These are multiple mechanisms through which bronchodilation can be achieved. In bronchodilators, the first group is sympathomimetic drugs. Sympathomimetic drugs, non-selective drugs हैं जिस तरह epinephrine, ephedrine, isoproterenol. They stimulate the beta 2 receptor which is present in the bronchial smooth muscles and they cause bronchodilation. लेकिन ये नॉन सेलेक्टिव है, इसकी वजह से दे स्टिमुलेट अदर रिसेप्टर्स एज वेल, लाइक आइसोप्रोटेरेनॉल विल स्टिमुलेट बीटा 1 रिसेप्टर्स एज वेल, एफेड्रिन एंड एपिनेफ्रिन आर गोइंग टू स्टिमुलेट अल्फा रिसेप्टर्स एज वेल. सो नॉन सेलेक्टिव ड्रग से ये बात स्टार्ट हुई थी, लेकिन नाउ दे आर प्रैक्टिकली ऑब्सोलीट फॉर द ट्रीटमेंट ऑफ एस्थमा. एस्थमा के लिए अब वी हैव सेलेक्टिव बीटा 2 agonist which will specifically stimulate the beta 2 receptors in the bronchial smooth muscles. This includes short acting drugs such as albuterol and terbutaline, long-acting drugs such as salmeterol and formoterol, and there are ultra-long-acting drugs such as indacaterol and vilanterol. ये जो ultra-long-acting drugs हैं, ये specifically COPD में use होती हैं, asthma में इनका role बहुत कम है. And the long-acting drugs are specifically used in combination with the steroids for the prophylaxis. Beta-2 agonists are going to stimulate the adenyl cyclase via the beta-2 receptors. They are going to stimulate G protein coupled receptor, resulting in increased adenyl cyclase activity, which is then going to cause production of cyclic AMP from ATP. This cyclic AMP is a strong bronchodilator. Because of this bronchodilation, these drugs are the first line therapy for acute asthma. लेकिन जो शॉर्टर एक्टिंग ड्रग्स हैं हम उनको एक्यूट ब्रोंकोस्पैज्म में यूज करते हैं फॉर द इमीडिएट रिलीफ. द लॉन्ग एक्टिंग ड्रग्स आर टू स्लो to produce an immediate response, so they cannot be used for the acute bronchospasm. Rather, they are saved for the prophylaxis. Beta stimulation, beta-2 stimulation specifically causes skeletal muscle tremor, which is the most common side effect. One more thing is important, that the beta-2 selectivity is rare. ऐसा नहीं है कि beta-2 purely beta-2 ही stimulate होते हैं और beta-1 बिल्कुल भी नहीं होते हैं. There is relative selectivity और कुछ tachycardia at regular dose common है because of beta-1 stimulation. अगर बार बार patient repeatedly use करेगा inhaler को तो उसके अंदर arrhythmia के भी chances हैं. There is loss of responsiveness after multiple uses, after consistent uses, because of tolerance and tachyphylaxis, which is a major concern, because initially these drugs are very helpful in asthmatic patients, but आहिस्ता आहिस्ता इसको रिस्पॉन्स कम होना शुरू हो जाता है, स्पेशली इफ द पेशेंट इज रिपीटेडली यूजिंग द एल्बिट्रॉल इनहेलर, तो उसमें टेकीफाइलेक्सिस जनरेट हो जाता है और उसका रिस्पॉन्स एकदम से डिमिनिश हो जाता है. देयर आर सर्टेन पेशेंट्स विद COPD जिनको मोस्ट ऑफ द टाइम साथ में कार्डिक डिजीज भी होती है. ऐसे पेशेंट्स में एरिथमियास के चांसेस और ज़्यादा इंक्रीज कर जाते हैं, सो वी हैव टू बी वेरी केयरफुल. दिस इज़ वन ऑफ द रीजंस कि beta-2 agonists आर नॉट वेरी मच प्रेफर्ड इन COPD ट्रीटमेंट. COPD में हम मस्कुलिनिक एंटागोनिस्ट को ज़्यादा प्रेफर करते हैं बिकॉज देयर इज़ अ चांस ऑफ टेकीकार्डिया एंड एरिथमियास बिकॉज ऑफ द beta-1 स्टिमुलेशन विद द beta-2 agonist drugs. The next group in bronchodilators is methylxanthines. Methylxanthines में बेसिकली 3 मेजर methylxanthines हैं जो प्लांट्स से डिराइव की जाती हैं. One is caffeine, that is commonly found in coffee. The other is theophylline, which is commonly found in tea, and the last one is theobromine, which is found in cocoa. Theophylline is the only member of the group जो कि asthma के treatment के लिए important है. Theophylline की फिर आगे से multiple formulations बना दी गई हैं. Theophylline itself is orally active. It is available in prompt release forms. It is available in slow release forms. One problem with theophylline is that it's eliminated by the cytochrome system. So कोई भी cytochrome inhibitor होगा या cytochrome inducer होगा वो theophylline की concentration को alter करेगा within our body. Mechanism of action of theophylline or methylxanthines is a very commonly asked exam question. There are multiple mechanisms through which theophylline act. First and foremost, they cause inhibition of phosphodiesterases. Phosphodiesterase वो enzymes हैं जो cyclic AMP को break करती हैं. When there is inhibition of cyclic AMP breakdown, the levels of cyclic AMP increase. Now there are 2 isoforms of phosphodiesterase. Phosphodiesterase 3 specifically bronchodilation cause करती है, while phosphodiesterase 4 causes inhibition of the inflammatory cells. Secondly, there is inhibition of the cell surface adenosine receptor. अब उससे क्या फ़ायदा होता है? Normally, adenosine receptor stimulation causes contraction of the smooth muscles as well as histamine release. When we give something that inhibits these receptors, उसकी वजह से smooth muscle relaxation भी होती है और histamine की release भी inhibit होती है. The third mechanism is enhancement of histone deacetylation. अब ये क्या होता है? Histone हमारे जो है वो DNA की proteins हैं. Histone की acetylation is one of the core processes that is required for activation of gene transcription. Acetylation होगी histones की, gene transcription होगी, वहाँ से inflammatory genes जो inflammatory proteins हैं वो बनना शुरू हो जाएंगी. ये सारे process को हम inhibit कर सकते हैं अगर histones को deacetylate कर दिया जाए by certain enzymes which are called deacetylases. Theophylline and methylxanthines cause enhancement of histone deacetylation, therefore they inhibit the transcription and translation of inflammatory products. Another mechanism that helps theophylline in the bronchodilatory response is increased strength of the diaphragm, which makes breathing easier. Theophylline and all the methylxanthines cause stimulation of the central nervous system. This manifests as alertness, nervousness, insomnia, tremor, convulsions अगर high doses हो जाएं तो. It also causes cardiac stimulation, resulting in tachycardia and arrhythmias, also because they cause increase in the circulating catecholamines. ब्लड वेसल्स के ऊपर डुअल इफेक्ट होता है. डायरेक्टली जो हमारे मिथाइलxanthines है वो वेसोडाइलेशन कॉज करते हैं, बट दे कैन कॉज अ स्लाइट इंक्रीज इन ब्लड प्रेशर बिकॉज ऑफ रिलीज ऑफ नॉरएपिनेफ्रिन फ्रॉम द एड्रेनर्जिक टर्मिनल्स. Furthermore, there is diuresis and increased GI motility. Major clinical uses of methylxanthines are asthma and COPD. Slow release theophylline is used for the control of nocturnal asthma. ये oral form में available होती है, prophylactically use किया जाता है. Aminophylline is the form that is used for intravenous administration in cases of acute bronchospasm which present in emergencies and are not controlled by the beta agonist or muscarinic antagonists. Roflumilast is an oral selective phosphodiesterase 4 inhibitor, and since phosphodiesterase 4 inhibitors are specifically helpful against the inflammation, तो ये COPD के पेशेंट्स में ज़्यादा यूज़ किए जाते हैं. Pentoxifylline is one of the methylxanthines that because of the vasodilatory properties and because it decreases the viscosity of blood, it is used for the treatment of intermittent claudication. All the methylxanthines have a very low therapeutic index. Gastrointestinal upset cause करती हैं, anorexia, abdominal discomfort, nausea, vomiting. ज़्यादा doses पे CNS symptoms आ सकते हैं such as headache, anxiety, tremors and convulsions at high doses. And CVS, since they cause tachycardia, this will be manifested as palpitations and arrhythmias in severe cases. If you did find it helpful, please like it and subscribe and share. Thank you.